Thank you, Dr. Praveen. Thank you, sir. Thanks for joining us. With this, we move on to our next important session for the day, that is tumor lysis syndrome. To chair the session, I would request our Associate Director, Medical Oncology, Dr. Sumit Goyal, to kindly step on the stage, and our Senior Consultant, Department of Hemat-Oncology and Bone Marrow Transplant, Dr. Narendra Agarwal.
Good afternoon, everybody. Thank you, organizers, for calling us for this great session. It's my pleasure to invite Dr. Pankaj Goyal for delivering next talk on tumor lysis syndrome, which is a kind of medical emergency in most of the hematological disorders and oncology. Dr. Pankaj Goyal, please. He is a well-known figure in RGCI and out of amongst Indian fraternity of oncology. He has 10 years at RGCI and currently working as a consultant in medical oncology. Overall, he has more than 20 years of clinical experience in medicine, pulmonary medicine, and thereafter medical oncology. He completed his post-graduation in chest and TB from PGI MS Rohtak, and he has rich experience in management of solid cancer, and he also cleared European Certified Medical Oncologist exam conducted by ESMO Medical Oncology. Dr. Pankaj has keen interest in clinical research and research ethics. He is an active member of a number of professional bodies, societies including ESMO, and he has presented many oral papers and posters in national and international conferences. Dr. Pankaj, over to you for tumor lysis syndrome.
Thanks a lot, sir, for that kind introduction. And to start with, if you talk about practice of medical oncology, if 20 to 25% of medical oncology is planning and giving chemotherapies, then 70 to 75% of it is managing the complications. And to talk on, I'm just highlighting few points on the tumor lysis syndrome, and it's more of a hematological issues, less of solid tumors. So I think Dr. Narendra is rightly sitting as chairperson along with Dr. Smith, sir. So this is the flow, the way we will be going: introduction, definition, epidemiology, pathophysiology, clinical features, and management. So this will be a sort of revision of what you already know. So this is a tumor lysis syndrome, is a clinical condition that is caused by massive lysis of tumor cells that have accumulated very rapidly and disturbed hemodynamics. Most commonly associated with the hematologic malignancies that we will see, but also few solid malignancies. It is because of the release of intracellular contents, thereby nucleic acid, proteins, and electrolytes. The four electrolyte disturbances are important in this. They are hyperuricemia, hyperphosphatemia, hyperkalemia, and hypocalcemia. And it leads to multi-organ dysfunction and various complications. So there are various definitions. Most often talked about is Caro and Bishop. As compared to the old definition, they have incorporated that even if the patient is not treated, before treatment also the patient can have this tumor lysis syndrome. So they have added this 3-day prior also, and they have also considered that if the patient is already having some baseline disturbed electrolyte imbalance, they have also been taken into care of. So basically the uric acid, potassium, phosphorus, and calcium, these disturbances fluctuation of 25% along with any of the clinical features, thereby it could be deranged retinal seizures or cardiac dysarrhythmia. So high-risk tumors, if we talk about, they are like advanced Burkitt's lymphoma, advanced leukemias, then ALL, DLBCL, EML, and intermediate risk are again AML with the counts of 25,000 to 1 lakh, ALL, DLBCL also, if it is having not that much of non-bulky disease, it comes in the intermediate risk. So there are certain cancers in which we expect that the patient will definitely go in tumor lysis syndrome when we start. So we have to be vigilant, and we have to evaluate the patient frequently, maybe every 4 hours or 6 hours, when we are expecting that the patient is obviously going to go into TLS. Otherwise, there will be some electrolyte disturbances where we will be made to have a suspicion of tumor lysis syndrome. So risk factors, as I have discussed, it could be high tumor burden, tumors where we have rapid cell turnover. If I talk about the solid cancers, the cancers like small cell lung cancer, or high burden ovarian cancer, or you say breast cancer, which are triple negative, they are also notorious that when we start treating these patients, they'll end up in tumor lysis syndrome. And also increasing age, and if they are having some underlying complications like renal dysfunction, and concomitant use of drugs like aspirin, cisplatin, or ethambutol or levodopa, if these drugs are also patient is using, then they are also at high risk. So this is a complex series of events we'll discuss in the further slides. Usually occurs 24 to 48 hours after initiation of chemotherapy and may persist for 5 to 7 days or longer, depending on what type of treatment the patient is taking. And this may occur as early as 6 hours post chemotherapy. So that is that rapid it can be. So this is a pathophysiology. Basically, it's the cell breakdown. It could be breakdown of the cellular structure, the releasing of the DNA, which actually leads to hyperphosphatemia and hyperkalemia and hyperuricemia. Because of these complications, actually the calcium precipitates because of formation of calcium phosphate, and then it leads to renal failure. So this is a vicious cycle. Then it causes other symptoms like neuromuscular irritability and other symptoms. So hyperuricemia, we know that the uric acid is being taken care of with a urate transporter, urate 1, and when there is excess of uric acid because of the cell breakdown, then it is not able to handle that, and that basically precipitates causing nephrotoxicity by either the physical complications because of this peritubular capillary pressure, or a chemical complication like chemokine mediated inflammation. Signs and symptoms we are very well aware of. It will be nausea, vomiting, azotemia, oliguria, and decreased urine output. And then phosphate, we know that the cancer cells are rich in phosphate. So when they break down, they have a precipitation with the calcium, and this in turn leads to acute renal failure. So the symptoms will be related to hypocalcemia and the renal failure, and also hypertension. Hyperkalemia, since there is lot of cell lysis, so this is the first thing which we usually find, that the potassium level is rising, and the kidneys are not able to deal with the in excess potassium which comes acutely. And if the patient is having a underlying renal dysfunction, say the patient is already a diabetic, or the patient is on some NSAIDs, these are the patients who have more likely to have these complications. So this can cause, as we know, that ECG changes, weakness, twitching, nausea, and diarrhea. And hypocalcemia, as we see that it is not the direct complications because of the increased phosphate which precipitates, and the cause is hypocalcemia. And at times we'll have to go for the ionized calcium to see how much actual hypocalcemia is there. So it can cause neuromuscular signs and symptoms, or it can cause ECG changes and diarrhea. Uremia, it is associated with all these complications. So management basically is important, is prophylaxis, that we have to take into consideration. If the patient is having high risk, then we have to use some prophylactic measures, and another is treatment if the patient is landed up in this complication. So risk stratification is important to assess whether there is evidence of laboratory or clinical TLS or diagnosis, to assess whether the tumor itself confers high risk, and assess the other high risk features. So in general, like these are the features which make the patient at high risk. In hematological malignancies where the tumor bulk is quite high, we can see the number of lesions the patient is having, along with the bone marrow involvement, how much bone marrow is involved, how much splenomegaly is there. That will also be an indirect indicator of the load of the cancer cells, then hepatomegaly and the renal dysfunction. So these all together give an indication whether the patient is high risk, intermediate, or low. And it's not that at a one point of time the patient will be high or low. So it's basically a combination of other factors. It will be the tumor volume and the type of tumor, which will put the patient into either of these risk factors. So basically, if it is patient is low risk, first thing is important is hydration. That when we start treating these patients, we have to make sure that the hydration is very good. Low risk, we can or we may not use allopurinol. Intermediate risk is usually these are institutional protocols that in what tumor, what prophylaxis we are using. So usually intermediate risk go for allopurinol, and high risks are the ones where we have to add raspberry case. So this urinary alkalization, I think people can have difference in opinion as far as urinary alkalization is concerned. So this is practice at many institutions that they give tablet soda bicarb routinely to these patients. But then there is other school of thought where they say, okay, we agree that if the alkalization of urine is there, the uric acid solubility will increase. But then xanthine and hypoxanthine are less soluble in alkaline conditions, so they precipitate before even the uric acid is formed. So this decreases calcium phosphate solubility as well. So urinary alkalization results in rising serum pH, free calcium may bind albumin more rapidly and exacerbate hypocalcemia. So as such, at present, there is more evidence that alkaline diuresis is not recommended. Allopurinol we have been using now and then. Doses roughly we use it 300 to 400 mg per day. It's basically per meter square, 200 to 400 mg per meter square. And doses are adjustment as for renal failure. We know the mode of action is a xanthine analog and acts as a competitive inhibitor of xanthine oxidase. And given for up to 7 days after chemotherapy, and some high-risk patients can be given for a longer time. So this is the way it works, xanthine oxidase inhibitor. And then it forms uric acid, and this raspberry case we know that is an enzyme that converts uric acid to allantoin, which is more soluble than uric acid. So allantoin is basically not that readily formed in humans, but with this becomes more soluble. So this is the way we use the prophylaxis. If the patient is having low risk, intermediate risk, we see that we use hydration comes first. Again, you have to keep a hydration of 2.5 to 3 liters roughly in all cases. And if the patient is intermediate risk, we add oral allopurinol. And we have to see all the parameters: potassium, phosphorus, uric acid, and calcium. And if the patient is high risk, then we use raspberry case. And if the patient has established TLS, also in those cases, raspberry case has been recommended. So febuxostat is another xanthine oxidase inhibitor. If the patient is having hypersensitivity to allopurinol, we may go for this. And raspberry case, we know that this is Asperger's derived recombinant urate, and it catalyzes the conversion of uric acid to allantoins. There have been contraindications, so it's recommended that it's always better that we rule out G6PD deficiency before we use this drug. They have having different dosing schedules. They have been dosing schedules of continuous 5 days dosing also. But then there have been various studies in which they have compared single dose versus 5 days daily infusion. So they say that it's highly effective for prevention and management of hyperuricemia even in adult risk for TLS. So single raspberry case was as effective, and that is being commonly used, that we use a single raspberry case, and depending upon the effect, we can repeat the dose. So this is another study in which they have used single 3 mg doses of raspberry case. So it comes with a cost, so we have to be sensitive that way we have to use this. So this is another study, a meta-analysis, in which they saw that single fixed dose raspberry case was as efficacious as 5 days continuous. So this are the best practices. If we see that consequences of TLS are dire, so immediate recognition is very important. So treatment, if we talk about the treatment of hyperkalemia remains the same. What we already know, that we have to use potassium binders, or we use insulin glucose. Similarly, if the patient is having but important is when the patient is having hypercalcemia, we should not just jump and try to treat the hypercalcemia, because that may lead to further precipitation of this calcium precipitates. So if the patient is having symptomatic hypocalcemia, then we treat. Otherwise, if we treat the underlying physiology, treating the tumor and treating the other parameters like this phosphorus and potassium, then that actually gets corrected by itself. And so this is the urine output. We have to ensure that it's well maintained. If we are giving 2.5 to 3 liter 500 deficit, that should be ensured that is there. And also role of diuretics, they are not recommended as such, but if the patient is having a decreased urine output in initial hydration, then single dose of diuretic can be given. So raspberry case we have discussed 1.5 mg can be used, or we can use 3 mg. And apart from that, we have this sivlamir phosphate binders, which can be used to take control of phosphate. And a reduction in urine output may herald worsening of renal failure. So use of diuretics like furosemide can be used in emergency management. So renal dialysis is another thing. This was new to me also, because renal dialysis, what we usually use is the intermittent. But this has been seen, if you use intermittent hemodialysis, there is control in these factors, again precipitation of this phosphates and uric acid. So it's advisable that patient goes for continuous dialysis. So that comes with a cost, not available at most of the centers. But again, if required, dialysis has to be done. The standard recommendations are same if the patient is having intractable hyperkalemia, hyperphosphatemia, or acidosis which is not being taken care of. So this is the flow diagram of the same what we had discussed. And with that, I'll conclude, and thanks a lot for patient hearing.
Thank you, Dr. Pankaj. That was a very beautiful and very precise and concise presentation. hematology, when we practice hematology, we are on our toes, mostly looking for tumor lysis syndrome. But in solid organs, we usually tend to forget, and we need to be vigilant in high tumor burden cases or neuroendocrine tumors, and the small cell carcinomas, so we can have this complication. We have very nicely elaborated all the points, especially hypocalcemia and urinary alkalization. They are the points which we usually forget. So if there are any questions for Dr. Pankaj? If there are none, I think he has done a wonderful job. Thank you, Dr. Pankaj.
Thank you, Dr. Pankaj.
Thank you.
Thank you so much, Dr. Pankaj. I would request our Director, Hemat-Oncology, to kindly felicitate the speaker of the session, Dr. Dinesh Bharani.
So he's the one who taught us the measurement of T-Rex.
Thank you, sir. I would now request Dr. Praveen Kaur and Dr. Saurabh Das to felicitate the speaker, the chairpersons for the session, Dr. Sumit Goel and Dr. Narendra Agarwal. Thank you, sir.